Good afternoon, everyone, and welcome to today's palliative care webinar, Managing Symptoms in the Last Day of Life. My name is Anna Dowd and I'm the manager of the Barwon Southwest Region Palliative Care Consortium, and I'll be your facilitator for this session. These palliative care webinars are brought to you by the Barwon Southwestern Region Palliative Care Consortium in collaboration with the Western Victorian Primary Health Network. I'd like to begin today by acknowledging the traditional custodians of the land on which we stand. I would also like to pay my respects to elders past, present, and extend that respect to Aboriginal people present today. I'm just going to start with some housekeeping. So this webinar will be recorded and you'll be able to access the recording freely on the PHN Learn YouTube channel. The link to access the recorded webinar events will be put into the chat. On the screen, you will see our upcoming webinars. We're just one remaining in June. The next series of webinars will be out soon, haven't been finalised quite yet. Many of you will be familiar with the Health Pathways, the free online resource with localised clinical and referral information for health practitioners. You will see on the slide here some of the related pathways available locally. Attendance certificate. If you've registered for the webinar not displaying your accurate first and last name, or are tuning into this webinar with a group of people, please type your full name into the chat box. Only administration staff at the Western Victoria Primary Health Network will be able to see this. This will ensure that we can issue you with a certificate of attendance. For this webinar, all participants will remain on mute. If you have any questions, please type them into the Q&A box and I will ask them on your behalf to the presenter during question and answer time. There will be a link in the chat box to complete the survey after the webinar, and we'll show this slide again at the end of the presentation. So for now, I'd like to introduce you to our presenter for today's webinar, Lisha Kuruvilla from Barwon Health, pharmacist and mum. Thanks, Lisha.
Thanks, Anna. I hope everyone can hear me. I'll start sharing my screen now. Can everyone hear me? Anna, can you hear?
Yep, I can, Lisha.
And the screen is fine as well?
Yep, perfect.
All right, thank you for inviting me. My name is Lisha, as Anna said, the palliative care pharmacist at Barwon Health. So today we'll be looking at anticipatory prescribing in palliative care and the principles of symptom management in the last days of life. So planning for the last days of life, how we manage the medications, how do you anticipate the symptoms, and try and put processes in place so that we can avoid unwanted hospital admissions or crisis at home. So we'll be looking in detail with some of the principles of anticipatory prescribing and symptom management at the last days of life. So today we'll be looking at medication management in the last days of life, anticipatory prescribing, what it means, and what are some of the medications commonly used in this setting, and what are some of the common symptoms and the medication used and some of the practice points related to that. And we might have a look at the catastrophic orders in case of severe bleeding that might happen at the end of life as well. So preparing for the last days of life, so it doesn't mean the last couple of days. The preparation does start much before that. things like planning for the last days of life, the goals of care, the place of death, what are the patient's and the family's wishes, and how we can respect those things and enable those wishes as much as we could. And one of the aspects, as a pharmacist, we will be talking about will be the review of medications, because a lot of patients will be on so many different medications because of multi-morbid disease states. And often people are on fairly complex medication regimes and on a lot of medications. So review of medications leading up to the last weeks and months of life is quite important to try and stop the medications that are no longer beneficial. So trying to simplify the medication regimes to make things easier for the patient, because there will be physiological and metabolic changes and difficulties with swallowing, all kind of issues, and kidney functions, deterioration of liver functions and things like that. So it is important to review the medications to try and streamline or try and simplify the medication regime as much as we can. And considering the swallowing issues, so people might have difficulty swallowing larger tablets. And then in that case, we might have to look at different formulations or different routes of administration, and change medications or change routes of administration if necessary, and anticipate and plan for new or worsening symptoms. So specifically looking at swallowing issues, people might, for example, people with epilepsy or seizures, they may be on multiple anti-epileptic medications, and most of them are oral medications. So we need to plan for things like when people are not able to swallow these medications, how do we manage their seizures? How can we prevent the seizures from happening? What kind of medications can we switch them into? So all of these things needs to be planned beforehand for management of symptoms at home. So deprescribing is quite an important aspect in palliative care, and especially in the last few months of life. So the medication review and planning involves, in the deteriorating phase, review the relevance of current medications. So things like anti-diabetic medications, your statins, the lipid-lowering medications, medicines for blood pressure, anticoagulants, things like that, whether are they still providing benefit, or do you need to review these medications and try and stop some of them or all of them, depending on which phase the patient is at. And the complexity of medication regimen. So if anyone had seen palliative care patients with multimorbid conditions, you would have seen they are on a lot of different medications with complex medication regimens as well. So especially with if people with Parkinson's disease and things like that, people might be on 5 or 6 times a day of dosing. So all of these things can increase the complexity of medication regimes. So we need to plan for how to manage this polypharmacy to try and simplify the medication regimes where possible. So the principles of symptom management include the symptoms could be a vast array of symptoms. So some people may not experience all the symptoms, but they often we anticipate people towards the end of life experience multiple things like pain or shortness of breath, things like delirium, having confusion, agitation, so a lot, nausea, vomiting. So a lot of these symptoms can occur concurrently, and medication needs to be, these symptoms, in most cases, it could be anticipated, and medications can be, or the plans can be put in place beforehand, so that the patients have these things in place at home. So identification, assessment, and management of the physical symptoms are essential and has a significant impact on quality of life for the patient. And then the cause, the benefit, and the burden of treatment, patient wishes, and goals of care needs to be considered in this setting as well. So the medication review and planning. So where possible, we need to continue the medications providing symptom management still. So if the patient is able to take medications And if they are still needing that for symptom management, it can be continued for as long as possible. Stop medications that are not needed for symptom management or if they are burdensome to use. Prescribe medications in advance for problems that are anticipated, as we mentioned before. And prescribe medications for breakthrough use. So for breakthrough things like nausea or pain relief, shortness of breath, those kind of things. Prescribe medications in anticipation and making those things available at home. And always consider the alternative routes to peroral or the oral route. So often subcutaneous, sublingual, those kind of routes may be necessary in this setting. So the common symptoms we would say in palliative care are pain, fatigue, GI symptoms including dry mouth, reduced appetite, nausea, vomiting, constipation, or diarrhea. Respiratory symptoms are fairly common as well, so altered breathing patterns and shortness of breath, and cough and hiccups can happen as well. Neurological conditions, issues like seizures, especially if the patient has brain mets or primary brain tumors, that can happen as well. And also if they have already epilepsy and then if the medication has to be changed in that setting, that can lead to breakthrough seizures as well. And physiological symptoms including anxiety, depression, delirium, dermatological issues like sweating and itch is fairly common. So patients has really itchy skin and that can really affect the quality of life. It can be due to the dry skin or it can be due to the disease state itself, like hepatic failure, increased bilirubin, those kind of things that might increase the skin irritation. So skin care, mouth care, those kind of things are quite important in the setting as well. And bleeding and genitourinary symptoms are also fairly common in the palliative care end-of-life setting. So the anticipatory prescribing means anticipating the symptoms and trying to get medications or systems in place or training in place so that the patients do not end up going into the hospital if that's not what they are after. And also, even if they are in the hospital, we will need to prescribe the PRN medications for breakthrough symptoms as well. So there are certain symptoms that, as I mentioned, they're very common. So things like pain, shortness of breath, agitation, and nausea, vomiting, those kind of things are fairly common. And often with the anticipatory prescribing kit, we often have these common medications like morphine, midazolam, things like haloperidol and buscopan included in the anticipatory prescribing kit for the patients to keep at home. So the guiding principles, it's just taken from the Caring at Home project. So people have the right to be supported, to be cared for, and die in a place of their choice, which we try and support where as much as possible. The role of the patient's family and carers in providing physical, emotional, social, and spiritual support and care is appreciated and respected. Family and carers are supported to understand the level of care they are able to provide. This is quite important because often with the anticipatory medications, the healthcare professionals might not be able to visit the patient multiple times during the day or multiple times at home to give these and the breakthrough medications. Often the carers needs to be trained, so they need to have a bit of an understanding about what is involved. So being a loved one for a dying person and also being a carer who is needing to administer the medications for them, that can be often difficult. So it is important to talk to the family regarding what is anticipated and whether they are actually able to provide that, in addition to being dealing with their own grief and the emotional process of that as well. So the role of anticipatory medication is discussed with the patient, if appropriate, and the family or carers in the context of death and dying, and respecting the patient's specific spiritual, religious, and cultural needs as well. And as I mentioned, willing and able carers can be supported, but then In most cases, at home setting, we need to have willing and able carers to be able to have these medications managed appropriately at home. So there are services like palliative care at home and hospice care and things like that, where you have the healthcare professionals able to visit patients during multiple times at home, but it may not be possible for all the patients, especially if they are living remotely or not within the catchment area of some of the services as well. So all members of the multidisciplinary team support carers who are willing and able to give subcutaneous medications to help manage breakthrough symptoms. So with the anticipatory prescribing, we need to prescribe medications, as I said, in advance for problems that are anticipated. So the rationale for anticipatory prescribing is rapid access in the community. So, if there is symptoms at 2 a.m. in the morning, there is medications at home if necessary, rather than trying to access medications at after hours and weekends and things like that. It's quite important to anticipate. The anticipatory prescribing is quite important in this setting. And to avoid crisis at home or to reduce unwanted hospital admissions. And also with the anticipatory prescribing, we need to look at the enteral and parenteral routes of administration and aim to maintain the quality of life for the patient. So the anticipatory prescribing is also known as preemptive prescribing or SOS medications or palliative care emergency medications. So these are all interchangeable kind of terms for medications you prescribed in anticipation of symptoms at the end of life. So there are some contraindications where the anticipatory prescribing or the medications are not kept at patient's residence. So that could include the person or the carer are not willing to have anticipatory medications prescribed or stored at home, or medications are unable to be safely stored in the home for different reasons, or there is suspicion of medication diversion, or if there is active IV drug abuse at the home. And always there should be a risk assessment that has to be carried out before keeping these medications at patients' home, because these are high-risk medications as well that are prone to be diverted or abused as well. So also, depending on where the patients are, there are sometimes challenges in obtaining these medications. So some of the medications, as we go through the list, you would notice that they are non-PBS and they could be fairly expensive for the patient. So if they are linked with the hospital, then the medications may be funded in different ways. But if they are in the community, or getting this medicine through a community pharmacy, the medications cost is often a big barrier for end-of-life care at home as well. So looking at the common symptoms that we anticipate and provide medications for, so the main symptoms we see is pain. So pain is often present in most cases. Up to 80% of the patient would have pain towards the end of their life. And also it can be non-cancer pain or cancer pain. And also nausea and vomiting is fairly common. Constipation, altered breathing patterns or dyspnea, excessive respiratory secretion or noisy breathing, especially in the last weeks of life, is quite common as well. Seizures, agitation, restlessness, delirium. And also some of the things we will anticipate is if the patient is extremely distressed, then looking at sedation to manage that distress as well, that can be anticipated and medications organized beforehand in that setting. So the anticipatory prescribing, they anticipate the likelihood of specific symptom in a patient. For example, a patient already with advanced COPD may have, things like shortness of breath at the end of life. So that can be anticipated quite easily. Or the patients with heart failure, they may have increased respiratory secretions and things like that. That can be anticipated. Patients with cerebral meds, seizure can happen in that setting. So medications can be prescribed for seizures. So not all the medications available for these symptoms need to be prescribed in the first instance. Often you prescribe the pain medication and anti-nausea medication and medicine for agitation in the first instance, and the other things like medications for shortness of breath or medications for secretions and things like that are prescribed on an as necessary basis. And include the indication for each medication in the treatment chart, and consider the place of care, availability of medication, who will be available to manage the medication, and also the quantities of medication prescribed as well is important to consider. I'm not sure whether people had seen a palliative care schedule in the pharmaceutical benefits scheme. The palliative care schedule actually provides an increased quantity, enables an increased quantity of medication to be prescribed in palliative care patients. For example, for metoclopramide injections, often usually you can only prescribe 10 ampules, but if you're prescribing for a palliative care patient, you can actually prescribe 40 ampules with 2 repeats on it in the same prescription. So consider those kind of things as well if you need increased quantities of medications to be prescribed, whether these are available through the palliative care schedule. In that case, that can help in reducing the cost for the patient or for the family as well. So we might quickly look at some of the symptoms. I have looked at your schedule for the rest of the year. You're looking at the different symptoms in detail, but I will just touch on some of the common symptoms and then some of the medications that we commonly use in this setting. So pain, as I mentioned, is fairly common and can occur in a majority of patients towards the end of life, towards the last days of life. It can be due to the disease itself, or it can be due to the reduction in mobility and being in the bed, in the bed for a longer period of time, so leading to back pain and things like that. So the pain is fairly common, and often we will need to manage medications or prescribe medications preemptively for most patients in that setting. So the new pain can also develop. So it could be because of their disease state, or it could be new pain at the end of life. Consider the reversible causes or exacerbating factors if there are things which we can reverse to manage pain. So things like urinary retention, pressure area, back pain due to immobility, things like that. And the pain can often be expressed as agitation if the patient is not able to verbalize that they have pain. So it is to anticipate those cues as well, whether the agitation is actually due to the pain. So the anticipatory prescribing for pain management, opioids is one of our very frequently and commonly used medication. And it is over 75% effective in cancer, the pain due to cancer. And it is somewhat effective for non-cancer pain as well, but there are some pains that are not very sensitive to opioids. So in that case, we'd love to look at the other mechanism of actions of medications as well. So you probably are all familiar with morphine, which is commonly used for pain management and also for shortness of breath in this setting, because there is a lot of experience with the use of morphine, and also it's fairly inexpensive as well. So and it is easily available. It is in PBS, so there is a lot more experience with the morphine. So it is available in different forms like the morphine liquids, tablets, and morphine injection, and different strengths as well. So hence it is fairly commonly prescribed in this setting. And the doses can be started at a lower dose of around 2.5 milligrams and then increased according to the response. And also the morphine can be added onto the syringe driver if necessary for background pain relief. And also morphine is compatible with a lot of medications, hence it can be added with multiple things into the syringe driver as well. So it has pretty good compatibility profile with other medications. So the choice for pain management in case of opioids depends on the background medications, the cost, the effectiveness of the medication for the patient's renal function. So morphine is renally cleared and it can accumulate in renal failure, so might not be a really appropriate choice for patients with severe renal failure. And availability is an important aspect to consider as well, because these days you might have heard the morphine liquid is out of stock and a lot of opioids are being discontinued as well. So again, looking at what is available to prescribe what is available through the community or restricted to hospitals, it's quite important to know those supply issues as well. So some of the medications that are used as non-opioids in pain management are things like buscopan for colicky abdominal pain. Dexamethasone can be used for different types of pain, especially pain associated with spinal or central nervous system kind of issues. And non-steroidal agents like subcutaneous ketorolac is used as well as an adjuvant with other medications. So I put sufentanil in there because it's a lot of people might not have come across this and we don't use it very frequently also. It's a special access scheme medication. It's similar to fentanyl, but it is 10 times more stronger than fentanyl. Sometimes that can be used if higher doses of fentanyl are required. It's we haven't used it recently, but this is again, it is available if necessary. For fentanyl, it's often used in patients with renal failure, so that could be an option in that setting. Dexamethasone do have multiple indications, so it can be used for pain associated with tumor-related edema, spinal cord compression. Can also be used for things like refractory nausea, vomiting, things like bowel obstruction, raised intracranial pressure. So often in palliative care, when we simplify the medication regimes, we look at the other effects of the medication to try and use the multimodal effectiveness of the medication to treat multiple symptoms. So the dexamethasone can be used for nausea, vomiting, increased appetite, and for pain. So often those the multimodal activity of the medication can be useful in simplifying medication regimes as well. Similarly, morphine or the opioids can be used for pain management as well as for shortness of breath. So you're using the same medication for different indications. So with the dexamethasone, the usual dosing range is 4 to 12 milligrams oral or subcutaneously, daily or twice a day. And it is not often given via the syringe driver. The subcutaneous injection is just given as a bolus injection. And it is around 5 to 6 times more stronger than the prednisolone as well. So the pain management in the end of life days would be, the pain is often multifactorial. It might not be just because of the disease condition. It can be due to different causes. So often the complete pain relief is not possible. So we may need to use the opioids on deck. A combination of different medication may sometimes need to be used depending on what sort of pain it is. It can be a combination of neuropathic and opioid responsive kind of pain. So in that case, you might need to use a combination of 2 or more medications in that setting. Things like which opioid to use. They are all effective in the EQ analgesic doses. When I say about the EQ analgesic doses, you can look at opioid conversions, the tables, which is available through the Safer Care Victoria. If you haven't seen it, it's a really good reference to look at. So that's some of the things to be aware is like hydromorphone is much more potent than morphine. It's around 5 times more stronger than morphine. And there is some evidence that the hydromorphone is useful in patients with renal failure, as it might not impact the kidney function as much as it might the morphine might. And things like fentanyl, methadone, and buprenorphine may be more suitable for end-stage renal failure patients. And the adjuvant agents like the steroidals and non-steroidals and things like levomethomycin and neuropathic agents might be used to deal with the different mechanism of the pain. Another fairly common symptom is nausea and vomiting. So often we will prescribe things like metoclopramide or haloperidol or something like that for patients at the end of life or as part of our anticipatory prescribing. But one of the things is to look for any reversible causes and try to address that where possible. So a different kind of disease states can cause nausea and vomiting, and that can be managed or that can sometimes be reversed as well. Things like constipation or hyperglycemia, hypercalcemia, sometimes the side effects of medications that all can cause nausea. So sometimes just removing that cause might help in managing the symptom rather than adding on extra medications on top. So with the pain management, I will not go through this slide with the nausea and vomiting management. So there are different mechanisms that can cause the nausea and vomiting. So often looking at, what might be the cause for the patient's nausea and vomiting, that might help with our choice of medication. And another thing is patients with, say, Parkinson's disease, who is on levodopa, so a dopaminergic medication. Metoclopramide might not be suitable in that case because it's an anti-dopaminergic medication, and that can worsen the patient's Parkinson's symptoms. So again, the management of nausea and vomiting, the agent depends on the other conditions and what may have been causing the nausea and vomiting in this patient as well. So the common medications that we use is metoclopramide. Again, the common medications are common because we have used it quite frequently. There's a lot of experience with it. The syringe driver compatibility profile is pretty good for these medications. And also they are cheap and easy to access. So metoclopramide is the often first choice if there is no specific contraindication to it. Haloperidol can be used as well, and it has multiple receptor activities. And third line could be levomethomycin or cyclizine. Levomethomycin is a special access scheme medication, so that has to be obtained mostly through hospital pharmacies. Sometimes the community pharmacies can get it, but they are much more expensive, and they are non-PBS as well. So again, depending on where patients are living, some of these medications might not be possible in that setting because of the accessibility as well as the cost for the patient. So a bit more detail on the levomethomycin for patients who for people who haven't experience with it. So it's a special access scheme medication. So that means it's not part of the TGA approved medication. So it needs to be obtained as a special access scheme medication. So there is a specific approval form that the doctors have to do to obtain this medication. And it has multiple indications, the levomethomycin, because it has multiple receptor activities as well. It has pretty good anti-dopaminergic action and also antihistaminergic action as well. So it works in multiple receptors, and it can be used for nausea or vomiting related to multiple different causes. So it's an antiemetic, and it's also an antipsychotic medication. So it's antiemetic in low doses. So often for the antiemetic dosing, you might just need 6.25 to up to 25 milligram twice a day to 3 times a day, or it can be put into a syringe driver. But it can also be used in managing terminal agitation and delirium and for sedation. It's a highly sedating medication. So sometimes up to a maximum dose of 300 milligrams can be used for sedation in the last days of life for terminal distress. And it can also be used as an adjuvant in poorly responsive pain. But unfortunately, it has a highly likelihood of injection site reactions. So if it's put into a syringe driver, often it can cause skin irritation at the injection site. Cyclosine is another agent. Again, it's non-PBS and it could be a bit more expensive for the patient. It is available as a tablet as well as an injection, and it can be used as a second-line agent for nausea and vomiting associated with the bowel obstructions as well. So again, maximum dose of 300 milligrams in 24 hours can be used for cyclosine. It is incompatible with normal saline, so often we use normal saline to dilute a lot of the other medication, but cyclosine is the one which we need to be diluting with water for injection. So nausea and vomiting, subcutaneous route is preferred if the patient is actually having the vomiting, or if they have issues with absorption or things like bowel obstructions. Choice of agent depends on the availability, cost, and the patient factors. An anti-dopaminergic agent like metoclopramide, as we mentioned, is not preferred in Parkinson's disease. Ondansetron is sometimes used, but it's not preferred in the setting as it is highly expensive. It is expensive, and it's also constipating. So that might worsen the nausea and vomiting if the patients are constipated as well. Constipation is another symptom that can affect the quality of life for the patient, that can lead to other issues and complications. So again, if people are on opioids, we need to anticipate that it might affect their bowels, and patients might experience constipation. So prescribing the medications to ensure the bowels are moving is quite important in this setting. So I'm not sure how many nurses are in attendance, so it's one of the things you can ask as part of your regular review for your patients regarding their bowels, to make sure the bowels are moving properly, or put action plans in place to manage the constipation. I wouldn't go through the specific agent because these are all fairly commonly used, and I'm sure you're familiar with it. I'll just talk about methyl naltrexone or Relistor, which is a specific opioid receptor antagonist. And that can actually block the constipating effect of opioids in the gastrointestinal tract. So it does not cause the blood-brain barrier, and it does not antagonize the opioid reaction, the action of the opioid. So if your patient is on, say, high dose oxycodone or something like that, and if they have constipation that's not responding to the first line agents or the second line agents, then methyl naltrexone can be used as a third line agent specifically for opioid related constipation. So it is a subcutaneous injection, and it's a very fast acting medication. So within a few hours, the patient should have a response to it. So it is again available in PBS as well. So regarding the constipation, it's very common in palliative care, and sometimes overlooked in assessments. And the consequences can be abdominal pain, nausea, vomiting, can cause overflow, incontinence, fecal impaction, urinary retention, bowel obstruction, colonic perforation. So a lot of complications can occur with something that can easily or relatively easily be managed by asking the question about the bowels. Bulk forming laxatives, we often see patients on metamucil. That's not often preferred in this setting because they might not be drinking adequate water as well on top of adequate fluids. So that can lead to hard stools when you use the bulk forming laxatives like metamucil. So coming to the next fairly common symptoms that we see, which is dyspnea or shortness of breath or altered breathing patterns. So sometimes repositioning or maintaining a calm surrounding might help, or increasing the cool air movement around the patient or use of a fan might be helpful as well. Opioids or benzodiazepines are often used in this setting, like the lorazepam sublingual tablets is fairly commonly used. Often with dyspnea, it can, if people are anxious, that can lead to shortness of breath, and shortness of breath can lead to anxiety. So having a calming agent like a benzodiazepine might be useful in that setting. Opioid of the most common ones we would use is the morphine liquid. And as you mostly aware, the morphine liquid is currently out of stock everywhere. So we'll have to look at alternative approaches in managing dyspnea. So there could be other opioids that are available. So you need to talk to your pharmacist or the hospital or the doctors regarding what other options are available. Thankfully, the morphine liquid we heard is coming back in stock in August. So someone had taken over the Odin liquid and rebranding it. So hopefully we should get this back in stock at the end of August. So morphine for dyspnea, often a lower starting dose than is required compared to pain relief. So usually around 1 to 2.5 milligrams. And then in the syringe driver, you can use 5 to 10 milligrams and then adjust based on the response. With the Odin liquid, you often just start with 1 or 2 milligrams orally morphine liquid, and then 1 to 2 hourly PRN, and then based on the response as well. So lorazepam is the most common benzodiazepine that we use in this setting, but again, it's non-PBS and cost might be an issue for the patient. So clonazepam drops or midazolam, which is the subcutaneous option, can be considered as well. So the non-pharmacological measures are quite effective for managing dyspnea as well. So that include increasing the cool air movement, deflect the shower stream away from the face, adjust the posture, space activities, having written plans. So often in Bhavan Health, we have different care plans for managing shortness of breath or managing constipation. So it is good to have written plans in place so the patient or the carer is aware what to do in that setting. And psychologist involvement is often useful in managing dyspnea as well. So noisy secretions that can happen towards the end of life or in the last weeks and days of life as well. Often it is quite distressing for the patient's carers really rather than for the patients themselves. So the noisy respiration, the respiration is because they don't have adequate cough reflex and they may not be able to clear the secretions. So there is all that, it can be quite noisy. It might sound like the patient is struggling to breathe. So anticholinergics are often used in this setting to reduce the secretion, the actual production of secretions. So buscopan the evidence of effectiveness is lacking. So some people might have a response to it, but some people might not get any benefit. So you would know within the 12 to 24-hour period if it is actually effective for the patient. If it is not effective, that can be discontinued. Glycopyrrolate is again non-PBS and might be difficult to access in a community setting. So the respiratory secretions are caused by inability to cough effectively, swallow or clear secretions. And the anticholinergic, what it does is they will prevent the formation of new secretions, but it will not remove the secretions that is already present. So increased doses of the medication might not be of benefit, rather it might cause more thick secretions. So it can also cause anticholinergic side effects, including dry mouth, constipation, and things like swearing. And so the anticholinergic side effect might be quite uncomfortable for the patient as well. So that need to be considered in prescribing the anticholinergic medications for secretions. The medications for seizures, patients with primary brain tumors and brain mets are at increased risk. So the clonazepam drops are fairly commonly prescribed in this setting, and often the carers are trained on how to use the clonazepam drops in this if a seizure occur in the community setting. And patients could, the carers could also call the palliative care for more advice on how to manage the seizures. Midazolam is another agent that might be available, so it can be used subcutaneously, and also the plastic ampoules can be used for sublingual administration. So, depending on what is available in the local area, clonazepam or midazolam can be used interchangeably as well. So the clonazepam drops, so the dose is to be counted into the dropper, insert in the bottle. So you just need to count that into a spoon. And then one drop is equivalent to 0.1 milligrams. So often for seizures, a higher dose is needed, like 0.5 to 1 milligram. But it can also be used for agitation at a lower dose for up to 0.5 milligrams can be used, 0.2 to 0.5 milligrams can be used for agitation in the palliative care setting. Carer education is quite important when you are placing clonazepam drops in patients' home, so that people are aware how to use it in case if they have to use it. So that leads to the next symptom, the restlessness, agitation, and delirium. So the medication are similar as with the seizures. So the clonazepam, midazolam, and sometimes the haloperidol can be used in that setting. So the doses are in the slide, so I will be going through specifically with that. So we might spend a bit of time on the refractory distress. So the distress is fairly common in the last days of life. So patient can be agitated, can't find, it could be physiological or it could be psychological distress. So there is a lot of things going on, and often to manage the distress, a medication that is sedating might be the way to go. So the first line options are the benzodiazepine. So we frequently use midazolam in this setting, sometimes haloperidol. But if patients are not responding to the first line agents, then levomethomycin, as we mentioned before, it can be used for nausea or vomiting in a lower dose. But often in higher doses, the levomethomycin is used for refractory distress. So you can use often we see up to maybe 200 milligrams, but in some settings up to 300 milligrams can be used. Same with phenobarbital, which is highly sedating as well. That can be used in the terminal distress. So up to 800 milligrams in 24 hours in a syringe driver. It needs a lot of dilution because it is highly irritant to the skin. So sometimes you need to use a separate syringe driver if the phenobarbital has to be given via a syringe driver. I'm not sure if people have come across propofol, which I have seen once in my, 10 years of palliative care. So that can be sometimes used as a last option for refractory agitation. But we haven't really used it recently at all. But this is another option that people can use. But it is an IV infusion, so it needs to be used in a hospital setting, not in a home setting. So severe hemorrhage in palliative care and catastrophic orders. So that can occur in patients with advanced cancer or end-stage liver disease. So the hemorrhage can happen from different areas, like it could be a nosebleed or hematuria, hematemesis or vaginal bleeding, or through melena. So severe hemorrhage may be due to erosion of major blood vessels by the tumor, can be due to thrombocytopenia and other coagulopathies. So catastrophic bleeding can be very distressing, and the death can occur imminently in most cases, or so often there is not adequate time to give any medications in this setting. So the discussion with the patient and the family on what to anticipate and managing that in that aspect is quite important. So things like using dark towels and linen to disguise the visible blood that might cause distress to the patient and the family, packing and the medication to relieve anxiety, and subcutaneous lines in place for morphine. Those kind of things need to be considered in patients with head and neck cancer or patients with at high risk of catastrophic bleed. So these are the common medications that are prescribed for catastrophic bleeding. So things like midazolam and morphine. The aim will be to sedate the patient as quickly as possible. But as I mentioned often before, the medications can be done. If it is a large bleed or a major blood vessel, the death can happen quite immediately before you can actually administer the medication. So some of the things that need to be considered are getting the action plans done to manage some of the symptoms for the carers. So the carers are aware of what to do when the patients have symptoms like breathlessness or constipation, pain, nausea, or vomiting. So it is important to keep the medications at home, but it is also important to make sure the patients and the carers are aware of what to do when these symptoms occur. So the carers training is quite important to enable end of life at home. So caring at home project. So I think most of you would be aware of this. So it has really good resources around caring for a patient at home, the carer resources, and it has also have resources for the healthcare professionals and various educational resources as well. So if you haven't seen this, I would highly recommend looking at this and looking at some of those information in their website. So in summary, as the patient approaches the end of life, it is important to expect new symptoms or worsening or existing symptoms. Plan medication management for the last days of life to avoid crisis and unwanted hospital presentations. And also anticipatory prescribing should be undertaken to manage symptoms effectively and to maintain patient comfort. So these are some of the references that you can look at. So the Safer Care Victoria website, it gives you a really good reference on the syringe driver compatibility and the opioid conversions. Therapeutic guidelines is quite useful, and it has a palliative care section, which gives you really good information on the end of life care, anticipatory prescribing, and the symptom management. And also the Caring at Home project, their website also has really good resources for people who are interested in or dealing with palliative care patients choosing to have end of life care at home or in the community setting. So that's the end of it. Sorry about the coughing in the middle. My apologies, but happy to answer any questions if you have any questions.
Thanks, Lisha. That was a lot of information there. So thank you so much. Does anyone have any questions? You can put them in the Q&A. We've got a couple of minutes. Well, looks like we don't have any questions, but Lisha, when you do your review of patients, do you find that you often have to cease medication?
Yeah, we often have to, because I think the thing with palliative care is there is a lot of prescribers involved. So, there's often multi-morbidity, and then different specialists involved in the care. So the GP, the cardiac specialist, and so often there is a lot, and then people are not comfortable to stop medication started by someone. So yes, it is quite an important thing to weigh which ones to stop and which ones to continue and which might provide benefit, and also important to look at whether the patient are actually able to take these medications towards as they approach the end of life. So yes, we definitely do still seize medications.
Yeah. Thank you. I haven't had any questions come up in the Q&A, so I guess just want to say thanks so much, Lisha.
No problem. Thank you.
Quite a few people saying thank you, and that about, are you happy for it to be shared for,
That's fine. Yeah.
Yeah. All right. Well, thank you so much.